Well, I'm Dr. Victor Gonzalez. I'm a retina specialist out of South Texas, and I'm going to talk to you a little bit about the current applications of lasers in the anti-VEGF era. Uh, as you may have heard and known, there are a lot of my colleagues who say very early on when we start using these anti-VEGFs, it's time to throw away our laser. And obviously, that has not turned out to be correct. As you will see, even within our important clinical trials, the use of the laser was very important in achieving the visual outcomes that we achieved in many of the clinical trials that I'll be discussing today. Um, the Today, what I want to do is first sort of go through some of the headaches that we run into when we're doing these treating these patients. Today, I will be talking a little bit about what variety of different diseases we can still use the laser in. Um, Anti-VEGF definitely has become first-line therapy, but I think there's a limit in a very reasonable time period in which we can determine whether or not this medication is working. The There is very good evidence for us to understand exactly how it is that tissue-sparing laser is having an effect on the retina. And I think you'll see that understanding that will help you understand how to apply the laser and how to retreat these patients when retreatment is necessary. We have a large retina practice. There's 7 of us doing retina. We have 3 fellows. A large population of diabetics. About 25% of the population is diabetic, so we have a very significant number of patients there. 28% of the population is underinsured, which means that a lot of these patients unfortunately show up with very significant disease by the time they present to us. Like South Florida, we get a large influx of the Midwesterners with a lot of AMD between the months of October and April. So we see a broad spectrum of disease in our patients. And we do have a large research center which has been involved with most of the major anti-VEGF and device studies for retinal treatment. Now, here's the frustration, and this is something that very early on, although I trained in Boston and the anti-VEGFs are very dear to my heart, very early on we found out that there was a limit as to what they could do. So what do you do here? Patients got 20/40 vision, diabetic, you give them injection number 1, you give them injection number 2, you give them injection number 3. What is your next step? Well, if you look at the recommendations, they recommend that we continue to treat this patient. But for me, once I've not seen a very significant clinical response with the anti-VEGFs after 3 injections, I start looking and reevaluating my options. If I use Protocol T and I'm not using EYLEA, well then I'll move to EYLEA, even though the visual acuity is good. And if you remember, if your visual acuity was 20/50 or better, it didn't really matter which drug you treated. But in order to make myself feel better, if I'm not used EYLEA, I will give it a try. 1 or 2 or 3 more, or if I have been using EYLEA, then I need to look for another alternative. It's not to say I stop giving EYLEA. I will add something to the EYLEA in these patients. So now, let's look at some of the major clinical trials that brought the anti-VEGFs to the level that they're at now. This is Protocol I. In Protocol I, what we did is we looked at using laser immediately with the anti-VEGF or delayed application of the laser. And in this case, it was Lucentis or ranibizumab. And as you can see, the drug effect was better compared to the laser alone. And it really didn't matter at year 1 whether or not you used the laser early on or delayed. But interesting enough, as you can see in year 2, there was a separation. And the group that used the thermal laser lost some vision compared to the group that didn't use as much thermal laser. Okay, so very early on there was a hint that thermal laser in the old fashion was probably not the best way to do it, which is why there was such an interest on things like micropulse and endpoint management, and we'll get back to that a little later. So, we had great outcomes. The visual acuities, as you can see, these patients did fantastic with the drug, whether you had laser or not. But here's the interesting part, and this is something that we all forget. 3-line gainers, of course, very good with the combination and the drug itself. The drying effect of the anti-VEGFs were fantastic, but as you can see, laser works also. The old laser worked well. It just takes longer for it to have an effect. And here's the important slide here. In Protocol I, as you can see, about 30% of the patients required some laser. So in order for you to achieve those visual outcomes in a rigid clinical trial, 30% of those subjects required laser treatment. Now, how about Protocol T? Everybody's familiar with Protocol T. Here we're looking at the 3 major drugs that have been used to treat DME. And as you can see, Eylea or aflibercept had a better response compared to the other 2 at year 1. At year 2, the ranibizumab and aflibercept response was very similar. Look at those visual outcomes. Fantastic, using those drugs. Right. So what percentage of the patients in a rigid clinical trial required laser? And here it is. Oh. As you can see, depending on the drug, with bevacizumab or Avastin, over a 2-year period, 64% of those patients in that clinical trial required laser. The best drug, Eylea, 41%, and then ranibizumab was intermediate. So in order for you to achieve the visual outcomes that we did in Protocol T, if you're using Avastin, at least 60% of your patients should be having laser. If you're using Eylea, 40% of those patients should be having laser. And this is not really what you hear out there. So that's why you should never throw your laser away, because if you want to achieve the maximum benefit, you need to have the laser. Now, here's probably the most intensive treatment regimen is Rise and Ride. And here you see monthly injections for 2 years. Okay, so that's tough to simulate in everyday practice. But here, even in the most intense rigid clinical trial, what percentage of these patients received laser? Here it is. About 30+% of them, even in the most rigid clinical trial. So now, when I talk about laser, I'm not talking about that. That is not what we want to talk about. And this is why I want to introduce the concept of the tissue-sparing treatments, okay? And the PASCAL, I was a very early adopter for many reasons. Back when I first, used it, it was mainly all thermal. And of course, it's evolved since then as the data has evolved. And currently, we have a couple of these units. And why do I like this unit? Well, I think everything about the way we treat, how the sensitivity, the lack of pain that you can control with these patients, and for a very busy practice, an improvement in workflow. My PRP treatments, not only are they better tolerated, they tend to be more efficient, and I can get many more of them done in a shorter period of time. And of course, the tissue sparing aspects of this have been very important. Now, the next work is something that Daniel Palanker out of Stanford has worked on, and I think this is very important for you to really understand how it is that laser at this period works for us. I was never very comfortable burning the macular tissue, and as it turns out, I was right. And it wasn't the thermal injury that caused the benefit. It's the cells that survive that thermal energy that was important. Now, there's a there's a difference between ophthalmoscopically visible subthreshold. Subthreshold, as you can see in in the upper slide, you may not be able to see it, but there's still a histologic injury to the tissue. So you need to understand that there's a difference. Just because you don't see a burn does not mean that there isn't damage to the tissue. What we want to achieve is a clinical benefit with no loss of tissue, and I think that's where we're at right now with this treatment. This is the only physics I'm going to show you, and this is the Arrhenius integral, and what this shows us that real thick, the real small treatment parameter that we have between no treatment effect and thermal injury, and the Pascal unit, the Iridex Pascal unit now, is the only one that has this type of integral, your ability to really function within that zone without a high risk of thermal injury if you follow certain parameters that we'll be reviewing. So here is just a slide basically demonstrating the difference between subthreshold with injury and subthreshold with no injury. And you want to be on the far right of that slide and still have a clinical effect. And the dead cells are, is what you want to try and avoid. Now, what are you trying to do? Well, you're trying to increase the production of heat shock protein. And right around 30, and this is the endpoint management algorithm in the unit. And somewhere, if you titrate, and I'll review that, if you titrate to a barely visible burn, and then you invoke the EPM interval, you'll wind up right around 30%, and that's enough for you to produce a clinically significant production of the heat shock protein to get a response in these patients. Now, this is what happens, and this is what you're trying to avoid. Here on the far right, you have a full thermal burn, and you can see in the middle the orange are dead cells, and the green is cells that survive the thermal injury. When we then stain that same slide for heat shock production, you can see there's none in the middle, and then just that little edge where the cells survived are producing the heat shock protein. So you want to increase that activity in as much area as you can. And something like this. So here's the thermal burn on the right. You can see just the surviving cells are producing the heat shock protein. And then you leave that barely visible burn, and you invoke the EPM algorithm, and now look at the heat shock protein production, and all the cells have survived at that treatment. And that's what you want. So in a sense, when we use this particular module on the laser, it's like injecting heat shock protein into the eye. It's like an injection. And that's how I think about it, and you'll see how I do my treatments. Now, we had a consensus meeting of the EPM users worldwide, and basically this is what we determined at that time. We titrate at the 6 o'clock below the arcade to a barely visible burn. We then and you give it 3 seconds to make sure you don't visualize it. Just give yourself 3 seconds. And then once you do that, you've achieved an energy. Now, usually because we were getting ready to do some clinical trials, we wanted to limit the upper end of the laser just to try and make sure upper end of the energy to try and standardize everybody. It didn't matter whether you had the green or the yellow, 532 or 577, but we started at 100 and titrated it up. And even if we didn't see anything at 200, we still use that as our limit, only because we wanted to make sure that we try to standardize it. The exposure is 50 seconds, 200 milligrams, and 0.25 spots spacing. And then, your pattern comes in. The important thing was that the endpoint management energy was down to 30%, and that correlates with that slide that I showed you, that once you go above 45, you may be inducing a little thermal injury, and we wanted to try to avoid that. And the applications, you want to sort of paint the macula in order to increase the production of the heat shock protein. Now, so normally I'll put in anywhere between 500 to 1,500 spots. There's a pattern on the laser that gives you the central macular, and there's a little square that comes after that's completed, and then I just fill in any areas outside of that zone that have edema. Okay. Now, again, consider this as an injection, because that'll help you, when it is that you need to retreat and what to do when you retreat. My recommendation is that retreat, as you would with any other laser, every 3 months if you have to. And the way I increase my concentration of heat shock protein is by decreasing my spacing. So I'll go from 0.25 to 0. And even though you go to 0, you're only treating about 89% of the surface area. So it's not like you're really treating 100%, but that's enough for you to now have more space, more cells that are activated in producing the heat shock protein. And like anti-VEGFs, don't be surprised if it doesn't work for everybody. Now, one of the other important factors that you need to remember, and I'll point that out, is that unlike the anti-VEGF, it's not a rapid response. You got to remember, I showed you the slide, and just like the old laser, it takes a little while for it to show the response. And this is what that endpoint management view looks on the system. And when you pick endpoint management, it'll automatically take you to this, where you have the 15 millisecond exposure, the 30% energy, the 200 micron spot size, the 0.25 spacing, and the 500 micron inner radius. That comes automatic. At this point, when you have it on standby and you activate it, the only thing that you can manipulate is the energy. So like that, you can titrate your energy at the 6 o'clock position. And once you've done that and you come back, you're ready for your treatment. There is the opportunity to use landmarks. I don't use landmarks, simply because anything that's red on that central image will be a thermal burn. And what I have found over the years is that I don't need to do that. I know that I want to paint all that area. And as I mentioned before, I don't want to lose any tissue, because all the tissue that I can maintain is going to help my patients see better. So here is an older treatment. You can see there. That's what the landmarks look like, and everything in the middle, really doesn't have any thermal burns. But again, I use this just as an example. I do not like to use the thermal, the landmarks myself anymore. So what conditions can you use it for? Well, I'll tell you, CSR, this is my go-to for central serous. I don't do PDT rarely anymore. I can repeat this, and what I like about it is that, again, it spares tissue. It gives you a rapid response, and these tend to be young patients that are working and they want to get back to their business as soon as possible. DME, I'll be honest, I don't use it as first line, but as I showed you in that example, as soon as it's not responding to the level that I like, I introduce the laser very quickly. I will use it at first line if there's no center involved DME, but it meets the old, clinically significant criteria within 500 microns. Why? Because all the data for the anti-VEGFs is when it's center involved. And this works. We've got the data for the laser back then, and it should help us. BRVO, you know, if I'm treating BRVO and I have some residual edema, I'll add this as a adjuvant. And then, you know, interesting enough, there have been some very interesting work out of Brazil using MacTel, and MacTel is a structural problems with the Mueller cells, and there's evidence that using the endpoint management or subthreshold type lasers, including microperimetry, can activate the Mueller cell repair mechanisms, and you know we think that's why in MacTel it may also be very very useful. I've already mentioned this. You know, I don't use it as first line except in those patients and with DME that do not have center involved, and I'll repeat it every 3 months if I need to. But remember, again, be persistent and be patient. Here's a quick clinical example. Is a patient, 64-year-old, center involved DME, wanted to use the anti-VEGFs. You know, the lady wasn't too happy with the intravitreal injection and didn't want this anymore. And her choice was, you better do something else, or I don't want any treatment. And we all know that if you leave this patient untreated, they do poorly. But here again is an example of your patients. I started the treatment in 2012 with the endpoint management, and as you can see, there's a slow improvement over a year plus. But this patient eventually did very well, and we gave the treatment every 3 or so months. So remember, it's not an immediate wow effect like the anti-VEGFs, but if you're patient, it can certainly add benefit to your treatment if you're using the anti-VEGFs. And then, as we heard from an earlier talk, there is the ability to reduce the number of injections that you give if you use the anti-VEGF and the laser, as Dr. Paulus from presented earlier today, and I've had a very similar, very positive experience. So just to summarize, I think we all agree that at this point in time, the first line treatment for many of these diseases are the anti-VEGFs. However, I do think that because there is significant non-responders in this group, you can improve their outcomes of the non-responders. In the responders, you can, by adding laser, you can also decrease the treatment burden that you would need from the anti-VEGF therapy. I think that the evidence for how it is that tissue-sparing treatments are working is very strong now, and I think we need to feel very confident that adding this treatment for our patients can certainly dramatically improve our outcomes for many of them, those that are resistant, and even those that are responding, so that we can reduce the amount of treatment that we give these patients. Thank you for your attention.
Did you use micropulse at all, or just endpoint management?
The question is that if I used micropulse at all or endpoint management, the answer is that I used both. Okay, right now, because of the systems that I have, I only have micropulse in one spot, and I use the micropulse 577, but in the other places I have the endpoint management, so I use both. Now when my newer unit eventually comes out where I can have that opportunity, depending on how they're responding, I can go from one to the other.
Do you feel there's any advantage one or the other?
Question is that do I feel there's any advantage from one to the other? The answer is no. The only difference is that for endpoint management, we have a good consensus of how it is that I set my parameters. But I think that I've had an opportunity to talk to some of the world experts on micropulse, like Dr. Sam Mansour and a few others, and we've agreed that we're going to look at that. And we want to make sure that we come up with a similar consensus on how to get and standardize the parameters for micropulse. And I think once we do that, I think they're very good treatments, and it's whatever you're comfortable with.
Sure.
Question is, have I seen the diamond study results briefly? So you need to give them to me.
Anti-VEGF is first line. Do you look for a CMT to then indicate it's okay to start laser, or do you just have a number of injections in your head and then add laser?
The question is, do I use central macular thickness, CST, to determine how soon I need to add the laser? Well, I published a paper back in 2016. It was called the early analysis, and we looked at the protocol I, the drug group, and the objective there was to try and find what's the earliest I could predict how that my clinical response was going to be good with the anti-VEGFs. And what I did in that study is we stratified them, and those that gained greater than 10 letters, those that gained 5 to 9, and those that gained less than 5. And although we could begin to predict after the second injection, the strongest correlation was after the third. If you stratify them in in those lanes, they swam across pretty consistently for year 1, 2, and 3. So after 3 to 6 injections, you probably know who's going to do well with the anti-VEGF and who doesn't, and you need to start looking for some other treatment. That's not to say you stop the anti-VEGFs. You just add something to them that I think would be beneficial.
I missed it. Were the anti-VEGF injections 90 days in between? 30 days?
The question was the anti-VEGF 90 days? No, it was 30 days.
30 days.
It was monthly injections. And even after 3 monthly injections, you'll know if you're stratifying using that algorithm. We did the same with protocol T, same results.
Sorry, last one. If you have a patient with multiple injections, there's still fluid, but their visual acuity is stable, we can add a subthreshold laser to that patient.
Question is, if I have a patient who has had multiple injections, the visual acuity is stable, and
Still persistent.
and there's still persistent fluid. The data basically indicates, if you look at protocol, all the different protocols, that if there are a couple of things that are associated with vision loss long term in patients like that. One of them is persistent intraretinal fluid. So if they have persistent intraretinal fluid, that's bad. Second thing is, the seesawing effect. That's also associated with vision loss. So to answer your question, even if I have persistent fluid and I have a stable vision, I need to get rid of that fluid in order for me to know that I've maximized the vision, number one, on that patient. And number two, I want to make sure I reduce the risk factors of the patient losing vision long term. Drier is better. Thank you.